laser iridotomy in primary angle closure suspects. And this is a hugely important issue because of the magnitude of the problem globally. This is just showing the anterior chamber angle, which gives you a sense of the mechanisms that we're trying to change under using an iridotomy. Here you can see the ciliary body, the scleral spur, and the anterior chamber. Open and closed angles vary quite a bit. Angles that are open tend to have more anterior iris insertion, and here you can see a more posterior one and more bowing of the iris. The thickness of the iris can play an important role in angle closure, and here you see a very thick peripheral iris, whereas this one has quite a thin one, and that would make it much less likely to close or have pupil block close it. Here I'm showing the insertion again. This is a very distal insertion closer to the ciliary body. Actually looks like it's sitting on the ciliary body, and so that will make a big impact on who opens and doesn't open after iridotomy. Similarly shown here, the very big differences that we see. This is showing a pupil block configuration on the right. On the left, you have almost your classic plateau iris with a lobster claw appearance. And then this peripheral iris roll can certainly play a role in angle closure. When I'm talking in this paper, I'm going to review findings for angle closure suspects. So I want to briefly discuss angle closure terminology and who are these suspects. These are people with no evidence of disease. The posterior trabecular meshwork is not visible on gonioscopy for 180 degrees, and they have a normal pressure. And they have no glaucoma, no disc or field damage. And on your left, you see an open angle. And on the right, you see somebody who's a suspect because you can't see any structures. The reason that we include pressure in primary angle closure is we think that that's a secondary effect. So when we're calling people having primary angle closure, we allow for either the presence of synechia, shown here, or for an elevated eye pressure. And the reason is an eye pressure being elevated wouldn't happen very often by chance in a patient with narrow angles. If you chose a population with very high angle closure rates, let's say 20%, and you chose an eye pressure that was in the top 5%, well, the likelihood of those two things happening at the same time is about 1%. And that we think was highly unlikely. We reserve glaucoma for people with disc and field damage. And then there's this acute angle closure crisis, which I'm not going to discuss today, but it's an acute event with signs and symptoms and a very elevated eye pressure. Angle closure is a worrisome condition. If you look at China, which has very high rates of angle closure, the population is aging dramatically. There'll be over 600 million people over the age of 50 in 2050. And the question becomes, from a public health standpoint, what should we do with all those people with angle closure suspect status? Well, if you look in India at the Chennai glaucoma study, this gives you a sense of a population living out there, living and dying, coming and going, and this is what's left at the end. And you have nearly 300 angle closure suspects, 100 with angle closure, and only 34 with glaucoma. So less than 10% have real disease. That's a big finding, because if you only have less than 10% with real disease, is iridotomy worth doing? Well, what about the benefits of iridotomy? We looked at the island of Singapore at patients who'd had an acute attack, and we looked at the fellow eye, and this was 6 years later, and eyes that had had an attack had glaucoma, a lot of them, and a fairly amount of visual field loss. And 10% of eyes that had an attack were actually blind from glaucoma in that study. But the fellow eyes, which all had an iridotomy 6 years later, had very little disease. So this would argue, why not just do an iridotomy on everyone? Avoiding acute attacks makes sense. It's beneficial. And the other eyes did well after an iridotomy. And here's, a typical iridotomy shown. And the real question is this worth investing a large number of resources? Are we potentially harming people with iridotomy? What do we get for doing our iridotomies? What's the benefit? And so when we think of harm, we know that iridotomy can disrupt the blood aqueous barrier. There can be pressure rises and burns of the cornea. There can be glare and diplopia. We didn't know when we started the Zhongshan angle closure prevention study whether or not there could be cataract or endothelial cell loss. So we decided to randomize one eye of an individual to an iridotomy and leave the other eye untreated. And that's the Zhongshan angle closure prevention study, which was carried out in China, in southern China. We screened over 10,000 people for narrow angles and found nearly 900 with angle closure, and we followed them for 6 years. These individuals were on average about 60 years of age with a predominance of females. And this just gives you a sense of who they were. They were somewhat hyperopic on average, had shorter axial length, shallower anterior chamber depth, and otherwise healthy optic nerves. Well, what happens after you do an iridotomy to these patients? Is this potentially harmful? We gave brimonidine prior to doing the iridotomy, and about 10% had an elevation of 8 millimeters or more at 1 hour, but really very few had large spikes in pressure, and spikes were a little more common in shallower anterior chamber depths. We did, with an iridotomy, open the angles, and many of them were opened quite a bit, but about a quarter remained closed, which, as I showed you in the beginning slides, would be expected in some people who had more of a plateau or ciliary body configuration, or who had a very high iris insertion. And then the angle did decline over time, and this shows immediately after iridotomy, you have a fair amount of opening, and then there's a slow decline in both the lasered and unlasered eyes. What about the overall benefits of doing the iridotomy? Well, we had a composite endpoint in this study where a pressure of greater than 24 was considered an endpoint if it happened on 2 separate occasions, if a patient developed synechia greater than 1 clock hour, or if they had an acute angle closure attack. And overall, iridotomy was beneficial. If you look at the number of events, there were 19 in the iridotomy treated eyes and 36 in the control eyes, and that was a significant difference. But those are very low rates of events. We're talking about almost 900 people followed for 6 years, and these are the event rates. And if you look at what events happened, almost all of them were the development of synechia. And synechia is not disease, it's just a condition where we worry that pressure can go up. But if you look at actual pressure elevations, they were quite rare, only 8 individuals overall, and no difference between the 2 groups. And acute attacks was somewhat different. You can see there were 5 in the untreated arm. So 5 out of 900 people followed for 6 years, not many, but still more than in the acute attack arm, although given the small numbers, not statistically significant. 3 of the control eyes and 1 of the LPI treated eyes had the attack after dilation. And that's because we were looking for the development of cataract over time in these patients. That comes to very few acute attacks per dilation. And so if somebody needs dilation and you're worried that their angles are narrow, it's probably worth doing. And only 2 attacks occurred outside of dilation, which really means very few of the untreated eyes developed an acute attack. What about serious adverse events? Really, very minimal. And in terms of the corneal endothelium, there was a minimal statistically significant change over time. And there was no difference in development of cataract. So overall, LPI was protective, but mainly against interim outcomes, mostly synechia. Most cases of acute attack were following dilation. There were 2 control eyes over 6 years that had acute angle closure. And we may be doing too many LPIs. And this is Heming Guang examining one of our patients in the city of Guangzhou. This was a collaboration, Tin Ong, Heming Guang, myself, and Paul Foster, with a huge team of researchers. Thank you very much.
Hello, I am today talking about a new method of management of plateau iris that I'm going to present for the first time to this group. I just want to point out some financial interest areas here that I'm resolved. So we have a problem with angle closure, and as we know that iridotomy does treat angle closure, but it doesn't really deal with other mechanisms like plateau iris or bulky lens or ciliary body cysts. So plateau iris itself, of course, can be probably best defined as a narrow angle capable of closure despite a patent iridotomy. So the persistent angle closure despite a patent iridotomy. In this situation, of course, iridoplasty has been available, and you can, often see papers talking about the use of iridoplasty to pull the angle open by contracting the peripheral iris. This is a good technique, but unfortunately, some problems where corneal clarity or very shallow anterior chamber may result in endothelial damage. So really, we have shown that iridoplasty does help. You can see closer to the lower group here. You can see that parameters like angle opening distance and TISA and ARA are all improved statistically after the performance of iridoplasty and residual angle closure. However, you can see that also studies have been going on showing that iridoplasty may work a little bit or may not work depending on how severe the angle closure is, how much synechial closure you have, and how much of the other elements are in place, like how bulky a lens do you have. So this is problematic. You can of course have quite aggressive treatments like taking the whole lens out and doing endoscopic ciliary body ablation to reduce the plateau iris. But really, perhaps this is a little bit aggressive for patients with good eyesight and just residual angle closure after iridotomy, but no real big pressure problems or cataract problems. So a non-invasive option may be better. So besides iridotomy, iridoplasty, really what else can we do? What about the situation here where also, don't forget, the ciliary body itself, the ciliary processes, as you can see, may be actually pushing the whole iris forwards, and the ciliary process position may be the problem as well. And this needs to be addressed in any treatment. So iridoplasty itself thins out the iris, but has no effect on the ciliary body. So I thought that perhaps what if we went transsclerally and did micropulse in a technique that we call transscleral pars plicatoplasty. Plicatoplasty really was to address the underlying pathophysiology of the anteriorly positioned ciliary body causing plateau iris. And the hypothesis here is that if we treat the ciliary body directly with a low energy, not a mildly thermal laser without ciliary ablation, but with protein contracture, we can change the shape of the ciliary process. We tried this out on rabbits, took a bunch of Dutch-belted rabbits who have a naturally plateau type configuration, and you can see here that their ciliary bodies are anteriorly positioned, and after treatment you can see there is a thinning of the ciliary body, and the histopath here shows clearly that the treated area has been thinned out. Encouraged by this, we took a bunch of human pilot study patients who had plateau iris mechanism confirmed on UBM, and did micropulse transscleral plicatoplasty for 60 seconds using 1.2 watts, divided between the upper and lower quadrants, avoiding horizontal, and we followed these patients up. Here's a gonioscopic Schaefer pre and post. You can see that the Schaefer gradings have gone from mostly 1s to mostly 3s, so we were encouraged by that. Here's some of the anterior segment OCT pre and post laser. You can see there's a difference to the iris insertion as well. And if you look at the actual ciliary body on UBM, the ciliary body has changed position and the angles have opened up post laser, which would be showing that we can somehow modify the angle shape by transscleral laser. And here we have some UBM parameters. We can see that the angle between the iris and the ciliary body posteriorly has increased in the treated group versus the untreated group. But these are small numbers. This is as a pilot proof of concept. So we have a little therapy here now that seems to be able to modify anterior chamber parameters by inducing mild contraction of the pars plicatum ciliary process without causing thermal explosive damage. And the micropulse transscleral cyclophotocoagulation or transscleral plicatoplasty may be able to result in a posterior vector of the iris lens diaphragm movement and increase the anterior chamber depth, and hence decrease the angle closure. This is gentle local anesthesia procedure and does not require any formal contact lens or slit lamp use. And we hope that we can do more studies on this to further refine the laser settings and create a more customized delivery system for this therapy. And we will compare this against arterioplasty alone in the treatment of residual angle closure is the next step. I thank you for your attention, and I thank my team who's been working with us on this new therapy. Thank you for your attention.
So my name is Ming He. I work for Melbourne University and also Centre for Eye Research Australia. So today is my great privilege to present something on, in particular, on phaco as a primary procedure for primary angle closure and primary angle closure glaucoma. So this is my financial disclosure. A number of years ago, like in the past 20 years, a lot of population-based study has been done in the ex-Asia population and also in other European population. So quite interestingly, if we use a uniform or similar methodology, we actually report the prevalence of angle closure suspect and primary angle closure and primary angle closure glaucoma. Actually, it's very similar in Mongolia, Singapore, and Guangzhou, around 10.6% primary angle closure suspect, 2% primary angle closure, and 1% primary angle closure glaucoma. So hypothetically, the primary angle closure should be developed on the basis of a narrow angle eye. We call it primary angle closure suspect. And then some patient might develop a peripheral anterior synechia and also intraocular pressure elevation. And we got to bear in mind or remember that a majority or all of the primary angle closure glaucoma cases, they are all IOP dependent. So after IOP elevation develop, and then we have go ahead proceed to primary angle closure glaucoma. And laser peripheral iridotomy is very considered as a primary treatment for angle closure, in particular primary angle closure suspect and primary angle closure, and including glaucoma. But then laser iridotomy primarily just eradicate or eliminate the pupil block mechanism. So after the laser iridotomy treatment, the iris got flattening, and then the drainage angle got open. So in our population-based study, we kind of proved that actually in 80% of the angle closure eye after the laser iridotomy actually managed to open the angle in 80% of them, but then 20% of the angle closure remained closed. And then primarily because of either the anterior rotation of the ciliary body or the Nash iris roll. So our Singapore colleagues actually many years ago published a paper, I think it's 2002, and then they kind of interestingly, they conclude that the efficacy of either laser PI or surgical PI for disease control really depends on the underlying mechanism, for example, pupil block mechanism or non-pupil block mechanism, and then also the stage of the disease. So a satisfactory IOP control normally achieved in more than around half of the cases with PI alone. If the glaucomatous optic neuromorphy is yet to develop. So before the GON develop, so this PI alone can achieve a quite good IOP control. But then after the GON is developed, so the PI alone is not that efficient, it's not sufficient anymore. So 94% or even 100% of the cases will require further treatment, for example, filtration and trabeculectomy and so on to control IOP. So quite interestingly, this is the OX study, ocular hypertension study. So they kind of demonstrate that with cataract surgery, actually this is a control group. After cataract surgery, the intraocular pressure can be dropped by 4 millimeters in mercury. And then this reduced IOP will persist up to 3 years after the cataract surgery. Interesting, huh? So then they assume this is because of probably the increased outflow secondary to the increased tension of zonule. So then if you look at anterior chamber change after cataract surgery, we can often observe an increase on the drainage angle wave. So in the anterior segment OCT scan, for example. But then now we got to pretty quite clear that cataract surgery alone is able to reduce intraocular pressure. But then phaco as a surgery, there's no question which should be recommended for people with clinically significant cataract. So if patient presented with clinically significant cataract, we should consider phaco. But the real question is, should we consider phaco for those people without or clinical significant cataract? So in other words, would a clear lens extraction make sense for PAC and PACG? So I think the EAGLE trial published in 2016 really set a benchmark on understanding the clear lens extraction and its role in angle closure treatment. So if you can see from the EAGLE trial, actually they enrolled the patient without clinically significant cataract. So let's look at the outcome. So when you compare in the EAGLE trial, you compare clear lens extraction with laser peripheral iridotomy. First of all, after 6 months, after 3 years, 36 months, so the clear lens extraction got at least 1 millimeter in mercury lower intraocular pressure. And then, but then more interestingly, if it's lens extraction only, there's only one case out of 200. More than 200 patients require trabeculectomy. But then this in the laser peripheral iridotomy laser PI group, I mean, this number is much higher. A lot of patients actually, they have required cataract surgery, for example. So, but then if you look at the angle width changes, because a lot of mixing data actually here, so this comparison between two groups is not that reliable. And then also the clear lens extraction, if you look at visual field function at the 36 month, there's not statistically significant between these two groups. And clearly, but then more interestingly, clear lens extraction with much less number of medication eye drops in the phaco group. And then I think the highlight of this study is really the investigator looking at quality of life. So in the phaco group, because the patient got much better contrast sensitivity, better visual acuity, so that they have a much better quality of life comparing to the laser PI group. And then this is a complication of the surgery in the clear lens phaco group and the laser PI groups. As you can see, a lot of iris intraoperative complication, like for example, iris prolapse and so on. So, but then when you perform clear lens extraction on the angle closure patient, you should pay attention to IOL power estimation. And then you also, when you really do the surgery, you got to pay attention to incision and make sure the iris won't collapse. And then we got to pay attention to iris elasticity and also protect the zonule. And also we got to, in particular, pay attention to aqueous misdirection and then to prevent the malignant glaucoma as well. So then, in conclusion, the phaco clear lens extraction, based on this, the EAGLE clinical trial, they should be considered for PACG, and primary angle closure with elevated intraocular pressure. Let's talk about particularly when we talk about 30 millimeter in mercury increase. Thank you so much.
Ladies and gentlemen, I'm Clement Tam from the Chinese University of Hong Kong. In this talk, I'll be sharing with you my thoughts on the relative roles of phacoemulsification alone, combined phacotrabeculectomy, and trabeculectomy alone in the management of primary angle closure glaucoma. These are my financial disclosures and also the government funding that has supported our work. Nowadays, we are all fully aware of the effect of lens extraction on PACG eyes. It dramatically deepens the anterior chamber, it widens the drainage angle, and also improves intraocular pressure control. Now, before I move further, let me first just get trabeculectomy out of the way. I think trabeculectomy alone in phakic PACG eyes has a very limited role, and this is because of the risk of an even shallower anterior chamber after trabeculectomy and also the risk of malignant glaucoma. Furthermore, 30%, there's a 33% chance of cataract progression in these eyes after trabeculectomy alone within the first 2 years after surgery. And in subsequent cataract surgery, the surgery can be technically more challenging with an increased risk of surgical complications. And also, the subsequent cataract surgery may compromise filtration and may decrease the efficacy of the IOP control from the trabeculectomy. Now, I think perhaps there are very limited indications for performing trabeculectomy alone in phakic PACG eyes, and these may perhaps include the younger patients with clear lens and no presbyopia and no significant refractive error. Perhaps in those eyes with a deeper central anterior chamber, which may suggest that the lens is not the main mechanism causing angle closure. And also, perhaps in those patients who are refusing lens extraction. Now, this is a randomized controlled trial conducted by our group directly comparing phacoemulsification alone versus trabeculectomy alone in medically uncontrolled PACG eyes. You can see that the red line represents those eyes randomized into receiving trabeculectomy, while the blue line represents eyes treated by phacoemulsification alone. And with time, over the first 24 months after the initial surgery, you can see that initially trabeculectomy did have an advantage over phacoemulsification in terms of IOP reduction, but with time, this advantage gradually diminishes. If you compare the mean number of glaucoma drugs that is required for these eyes, you can see that the advantage of trabeculectomy over phacoemulsification was very well maintained over the first 24 months. But I would just like to point out that even with just phacoemulsification alone, there's a very good reduction in the number of drugs required, which is also well maintained over this initial 2-year period. Now, in terms of subsequent surgery required after these two procedures, in the phacoemulsification group, almost 20% of the eyes would require trabeculectomy within the first 24 months, whereas in the trabeculectomy group, some eyes required phacoemulsification and also some required additional procedures to maintain filtration. Now, so because of the effectiveness of lens extraction in improving IOP control in PACG eyes, I think very often lens extraction will be the first intervention of choice in primary angle closure disease, especially when there's visually significant cataract and also when the lens is considered a major contributing factor to angle closure and IOP reduction is indicated. On the other hand, there are situations when lens extraction alone may not be sufficient. For example, if there is very advanced glaucomatous optic neuropathy necessitating a very low target intraocular pressure, or when there is grossly uncontrolled intraocular pressure with very high initial IOP and or very high dependence on glaucoma drugs. So under these situations, perhaps we need to combine the phacoemulsification with something else. And one very natural choice would be combined phacotrabeculectomy. Here in this graph, I'm showing you the results from another randomized controlled trial conducted by our group, directly comparing phacoemulsification alone versus combined phacotrabeculectomy in medically uncontrolled PACG eyes. You can see that once again, even with just phacoemulsification alone, there's a very good IOP reduction initially, and this reduction is well maintained over the first 24 months after surgery. But with combined phacotrabeculectomy, there's an additional IOP lowering compared to the phacoemulsification group, and this difference between the two treatments is also well maintained over 24 months. Now, if you look at the requirement for glaucoma drugs, once again, you can see more or less the same pattern. In terms of complications, understandably, the combined phacotrabeculectomy group was associated with more surgical complications. In terms of the longer-term clinical outcomes, about 19% of those eyes in the phacoemulsification group required a subsequent trabeculectomy during a 6-year follow-up period, whereas none of the eyes in the combined phaco trabeculectomy group required additional filtration. Now, while this may be slightly out of the scope of this talk, I would just like to add that, in fact, in between phacoemulsification and combined phaco trabeculectomy, I myself personally, I have also phaco ECP, which is combined phacoemulsification and endoscopic cyclophotocoagulation, slotted in between phaco and combined phaco trabeculectomy. So this, what I'm showing you here, is my own personal lens extraction treatment spectrum. You can see that from left to right, there is an increasing efficacy in IOP reduction, but of course, there's also increasing surgical invasiveness as well as surgical risk and risk of complications when you move from left to right. Now, this comparison table may not be completely scientific, as I'm drawing data from different randomized controlled trials, but you can see that generally speaking, in terms of IOP reduction, phaco ECP is somewhat in between phacoemulsification and phaco trabeculectomy. The same applies to drug reduction. And of course, with surgical complications, combined phaco trabeculectomy is associated with more. And whereas in terms of additional filtration surgery required subsequently, phacoemulsification alone group is associated with a higher chance. So I think at the end of the day, we have to take into consideration several important factors in reaching a surgical decision. First of all, we have to consider how much intraocular pressure and or drug reduction is required for a particular eye. We have to consider the preoperative intraocular pressure and drug requirement, the glaucoma stage and the target IOP, as well as the patient's age and the rate of progression of the disease. The other factor we have to consider is how much surgical risk the patient and the surgeon can accept for this particular eye. We have to take into consideration the status of the operated eye as well as the fellow eye, and also the patient's visual requirement, both for his or her work as well as for their hobbies. So I think the final decision will have to be made after very thorough discussion of the pros, cons, and risk of each of these surgical options with the patient. Thank you very much for your time and attention.
Hello, my name's Winnie Nolan, and I've been invited by the organisers to talk about goniosynecholosis and whether it has a role in the management of primary angle closure. I'd like to thank the organisers for inviting me to speak on this. I have no financial disclosures. So goniosynecholosis was first described in the 1980s and has been used by some clinicians as an adjuvant procedure to cataract surgery in the management of angle closure. In patients who have peripheral anterior synechia, so adherence of the iris to the trabecular meshwork, it involves manually separating the iris from the trabecular meshwork with using gentle pressure on the peripheral iris under direct gonioscopic vision. It can result in complications, which include bleeding, inflammation in the eye, which can be quite severe, and iridodialysis. This is a video showing a patient who had adult onset angle closure, but probably related to ROP as a baby. And here you can see following phacoemulsification. As for mixed gonioscopic surgery, the microscope needs to be tilted and the head needs to be tilted of the patient. And then using a direct gonioscopy lens, such as the Swan Jacob lens, and a long instrument, which you can see here is a goniotomy knife, but equally, if you have another less sharp instrument, that might be better, and one that just needs to reach across the angle. And you can see just applying gentle pressure there and directly pulling the iris away. You only need to treat the area that you can directly visualize. You don't need to move around the eye. That's often sufficient. And at the end, you should probably give intracameral dexamethasone due to the inflammation. Another option is viscogoniosynecholosis, which involves injecting Provisc into the angle or a viscoelastic without direct view, and this is also an option and it has been shown to be effective. The question really is whether it works and whether it helps control the intraocular pressure, and we're now in the position to look at and review evidence on this, which is very helpful. So I'm going to run through a number of trials, 2 small trials first of all. So this is one from Korea, patients with medically controlled PACG and cataract who are undergoing cataract surgery and were randomized to have phaco alone or phaco plus goniosynovial lysis. The follow-up was relatively short at 2 months, and they measured extent of PAS, drop in intraocular pressure, and reduction in number of medications in the 2 arms. Although the phaco GSL arm showed a slightly higher drop in pressure and meds, this wasn't significant. So the conclusion was there was no significant difference between the 2 groups, and it was a small study. Another small study from the UK, very similar, so small number of patients with cataract and PAS randomized to phaco or phaco GSL. In this study, they also measured tonographic aqueous outflow as well as intraocular pressure change, and they did find an increase in outflow and a reduction in intraocular pressure. And the follow-up was at 6 months. So this is relatively small numbers, but they did show a slight difference. This is a large trial from Rahat Hussain in Singapore, and these are patients with PACG and high pressure and cataract. Quite a large number of patients, so 78 patients randomized to phaco or phaco GSL. The table on the right shows the intraocular pressure bars for the 2 groups of patients at several follow-up intervals after surgery. The dark blue is the phaco alone and the light blue is the phaco GSL. And you can see that there's no significant difference between the 2 groups in terms of level of intraocular pressure. And they found no difference in other parameters such as number of glaucoma medications or PAS. And this had the advantage of long follow-up, so 1 year follow-up. The most recent RCT is from India, and this again is looking at uncontrolled PACG and randomizing to phaco or phaco GSL, 80 patients. The table on the right shows intraocular pressure at baseline and at several follow-up intervals in both arms, and there is a drop in both, but no difference between the 2. The conclusion of this trial was that there's no additional benefit of GSL when compared with doing phaco alone. And we also have the EAGLE trial, so many of you will be aware of this, and I'll just run through it briefly again. So this was a multi-center study taking newly diagnosed patients with PAC or PACG, and they were randomized to a clear lens extraction or laser iridotomy and followed up at 3 years. The inclusion criteria included raised intraocular pressure to different levels depending on the diagnosis, at least 180 degrees of angle closure, which could be appositional or synechial, and they were newly diagnosed with no cataract, and patients with extremes of axial length or cataract were excluded from this, as were acute angle closure patients. The primary clinical outcome was intraocular pressure, and there was a significantly lower intraocular pressure at 3 years in the clear lens extraction group compared to the laser iridotomy group. And you can see also the impact on the number of medications that were required. So a significantly lower number of patients required IOP lowering medication at 3 years in the lens extraction group compared with the laser iridotomy group. So if we go back to, if we look at the results of all those studies, I think in summary, it suggests that phaco alone is probably quite effective in reducing intraocular pressure and achieving long-term pressure control in patients with PAC or PACG. The trials that are available show little in additional benefits of phaco GSL versus phaco. The small trial showed an improvement in aqueous outflow, but really that was quite a small trial, and the large pragmatic trials show no difference in long-term intraocular pressure control. If patients have chronic long-term PAS, which they often do in these situations, they are unlikely to have functioning trabecular meshwork underneath the PAS. It is possible that more recent onset PAS, such as those in patients with an acute attack, may benefit from removal to improve the aqueous outflow, but generally speaking, phaco alone is very effective. Technically, it can be quite a difficult technique to learn, but we now do a lot of mixed gonioscopic surgery, so we're more happy with this technique and getting direct gonioscopic vision. PAS are notoriously difficult to measure, particularly in a patient with angle closure and a narrow angle, and it may be that phaco alone results in some division of PAS. And I think it's also worth considering that viscogoniosynechiolysis, which is a relatively easy technique of injecting a viscoelastic into the angle following phaco, is possibly effective at dividing the PAS, and it's less traumatic. So that just runs through those points again. And so in summary, I would say that in a short answer to the question, should we be doing goniosynechiolysis, I would say no, based on the evidence. And there's very little evidence that there's any role for this technique. Thank you very much for listening.
Hello, my name is Tin Ang from Singapore. My talk today is on acute angle closure. Don't panic. I'd like to thank the organizers for inviting me to give this talk. I have no financial disclosures. Acute angle closure is an ocular emergency. The very high intraocular pressure can lead to visual loss and damage from this high insult. However, if you have treat the patient quickly and promptly, and the patient responds to therapy, there often could be a good visual outcome. Acute angle closure can occur anywhere along the natural history of angle closure, which means it could happen in eyes with PACS, PAC, or PACG. The sudden elevation in eye pressure associated with close angle results in classic signs and symptoms. For the symptoms of acute angle closure, many of us will know patients have severe pain, headache, nausea and vomiting, blurring of vision, halos, as well as redness of the eye. And for the signs, you can see corneal edema, conjunctival injection, very high intraocular pressure resulting in a shallow anterior chamber, pupil that's mid-dilated and unreactive. Sometimes you may see iris atrophy from previous acute attacks and glaucoma flacken, inflammation of the anterior chamber, closure of the angle, and shallow and fellow eye as well. So how do you manage a patient with acute angle closure? Well, once you get the history and examination and get the diagnosis, the priority is to reduce the intraocular pressure. And this usually involves either giving acetazolamide or usually intravenously, or osmotic agents such as mannitol. Also, you can add aqueous suppressants and prostaglandin analogs, but beware of systemic medical conditions when you use these systemic agents. After intraocular pressure is reduced, the next priority is to reduce or break the pupil block element, because we know that pupil block is the main mechanism in acute angle closure. In pupil block, the resistance resides in the level of the pupil, and so aqueous builds up behind the iris, resulting in the increased convexity of the iris and further closure of the angle. And to break pupil block, you first need to put some miotics such as pilocarpine to constrict the pupil, as well as lots of steroids to reduce inflammation. And then the definitive treatment of pupil block, in order to prevent recurrence of acute angle closure, is either perform a laser peripheral iridotomy or phacoemulsification. Both treatments reduce the pupil block and prevent recurrence of acute angle closure and open up the angle. For laser iridotomy, you can either perform a YAG PI alone, or in Asian eyes, we often perform a sequential argon YAG PI, which means that we do an argon pre-treatment followed by a YAG to complete the iridotomy. This slide shows the effect of laser PI on pupil block. Before LPI, you can see the increased iris convexity and angle closure. And after PI, you can see the angle opens up and the iris flattens. Now remember to also perform the laser PI in the contralateral eye, because this eye is also at high risk of getting acute angle closure. Now, once you've done a laser PI and broken the acute attack, can you discharge the patient? The answer is no. These patients need close follow-up over the several following weeks, and you need to look out for the development of chronic angle closure glaucoma, in which case the intraocular pressure may rise and you need to add glaucoma medications. And over time, if medications fail, you may need to perform glaucoma surgery as well. So what about lens extraction? I mentioned to you that phacoemulsification is the alternative to laser PI in acute angle closure, as it also removes the pupil block element. However, remember that the acute angle closure presents very challenging conditions for surgery, such as corneal edema, shallow anterior chamber, and a hot inflamed eye. This picture illustrates why removing the lens will also reduce pupil block, because you will remove the element of pupil block at the level of the iris and pupil when you remove the lens. Several studies have compared laser PI versus phacoemulsification for acute angle closure. And I will quote for you two studies, one from Dennis Lam et al. From Hong Kong, and the second from Rahat Hussain et al. From Singapore. In the Hong Kong study, they randomized 62 patients with acute angle closure into phaco or LPI and followed up patients for 18 months. In the Singapore study, they randomized 37 acute angle closure patients into phaco or LPI and followed up these patients for 24 months. In both studies, they only recruited patients with visually significant cataract more than 20/30, and the main outcome measures was the IOP control, which means that they looked for a rise in IOP over time, as well as angle opening and number of medications. This Kaplan-Meier survival curve shows the results of the Hong Kong study. As you can see, the phaco group did much better, with only 3% developing a rise in IOP over time, compared to 46% in the laser PI group, with a hazard ratio of almost 15. In the Singapore study, the results were very similar. You can see here the phaco group only 0.5% developed a rise in IOP over time, compared to almost 40% in the laser PI group. In terms of other outcome measures, both studies showed that phaco was better in terms of angle widening, less PAS, as well as less glaucoma medications required. Also, there was no significant difference in the endothelial cell count in both groups. For complication-wise, there were some complications for the phaco group, including corneal edema, fibrous AC inflammation, and posterior capsule opacification. And for the laser group, 1 or 2 cases had closed iridotomies or small iridotomies that needed supplementary laser. So in summary, you can see that phacoemulsification is a good alternative to laser PI in terms of long-term IOP rise, as well as the reduction in medications over time. However, there's no clear consensus on the optimal timing for phacoemulsification. In both these studies, phaco was done within a few days of breaking the acute attack. However, right now we know that this could perhaps be a little bit more risky in terms of surgery, and perhaps you could wait a little longer for the inflammation to subside. So some tips for performing cataract surgery after acute angle closure is that just before the surgery, you could give intravenous mannitol or Diamox. Of course, pre-treat the patient with steroids, use iris hooks if necessary, or vision blue if the visualization is poor. This is an example of a patient with acute angle closure who underwent phacoemulsification. you can see the vision is good at 6/9 with good intraocular pressure, but you can also see the consequences of the previous acute attacks, such as iris atrophy and a large dilated pupil. Remember, acute angle closure are not easy eyes to operate in, and that there are great risk of doing phaco due to the difficulties of the surgery. In particular, you have risk of corneal decompensation, suprachoroidal hemorrhage, and so you should be quite experienced in order to perform such surgery. Now, in some acute attack cases, what if the IOP does not come down and the cornea is still hazy and you can't do a laser PI or a phacoemulsification? One option is to do an AC paracentesis using a blade, and this would provide immediate reduction in intraocular pressure, improvement of corneal clarity, and then you should do a laser iridotomy straight away after the paracentesis. However, paracentesis also has risk, including lens damage, endothelial damage, and suprachoroidal hemorrhage, as well as infection. Another option is to use a blade to remove the edematous corneal epithelium in one particular area, and this will then reveal a clearer stroma underneath for you to perform the iridotomy. The last option is to perform an iridoplasty, which are contraction burns in the peripheral iris, which will then pull the iris away from the angle. And for this, you need a low power, large spot size, and long duration. Iridoplasty has been described in one study to be an alternative to medical treatment in reducing the acute attack, as it clears the cornea and relieves symptoms faster than medical therapy. And in this study from Hong Kong, they found it more effective than conventional systemic medications in reducing the IOP within the first 2 hours. Iridoplasty can also be used to break the acute attack, which is non-responsive to medical therapy. However, there are some dangers of iridoplasty, including corneal endothelial damage and floppy iris during phacoemulsification subsequently, as well as visual disturbances. In conclusion, acute angle closure is an ocular emergency. The priorities in management are to bring the IOP down quickly and then to break the pupil block, the main mechanism for acute angle closure. For this, you should perform either a laser PI or a phacoemulsification as the alternative. Remember to do a laser PI in the fellow eye, and if you do a laser PI, watch out for chronic angle closure development, and you need to often add medical treatment over the long term. If you decide to do a phacoemulsification, remember there are risks of doing phacoemulsification. These are not easy eyes to operate in. Thank you for your attention.